Welcome to the lecture on renal system. In this lecture, we will talk about the body organs linked with the urinary system, including the kidneys, the ureter, urinary bladder, and the urethra. So let's start with the kidneys. Here you are looking at the posterior view of the human body. The bean-shaped kidneys are retroperitoneal organs located along the posterior abdominal wall in the paravertebral gutters, the spaces on either side of the vertebral column. Each kidney extends from the vertebra T12 and extends all the way down to the third lumbar vertebrae. However, the right kidney, as you can see over here, is a bit lower than the left one because of the presence of the liver on the right side. The position of the kidneys also varies with respiration. Kidneys are a bit tilted towards the midline, as you can see over here, with the superior pole lying closer to the midline than the inferior pole. Right, so now let's talk about some of the important anatomical relations of the kidney. In this illustration over here, you can see the two kidneys, the one on the right side here, the one on the left side over here. So you're looking at the kidneys from the front. On the superior pole of each of the kidney, we can see a suprarenal gland, which is the superior relation of the kidney. You can see the one on the right is triangular in shape, whereas the one on the left is crescentic in shape and extends down all the way to the medial border of the kidney. The right kidney is related anteriorly to the liver. The liver obviously has been taken out from over here, but you can still see the attachments, the ligamentous attachments or the peritoneal reflections, which are holding the liver in its position. For instance, on the right side over here, we can see the cut section of a ligament here called the coronary ligament, the anterior and the posterior coronary ligaments. Then we can see the cut section of the right triangular ligament over here. The two coronary ligaments combine to form this right triangular ligament, and similarly on the left side we can see the left triangular ligaments. These are just fancy names given to the reflections of peritoneum, which extend from the diaphragm and from the posterior body wall and then reach onto the liver to wrap up the liver and thus holding the liver in its position. So if we don't want to take the liver out of the body, we need to cut through these ligamentous or peritoneal reflections, which you can see now over here. You can also see an area of the diaphragm which is not covered over by the peritoneum. This is an area which is in direct apposition with the diaphragm, with the liver, and the area on the liver as well. The corresponding area on the liver also is not covered over by any visceral peritoneum, and that is known as the bare area of the liver. Then the right kidney is also related anteriorly to the C-shaped structure over here, which is the duodenum. You can see the first part of the duodenum here, the second part over here, the third part here, and then the fourth upturned part over here. Duodenum is part of the small intestine, and you can see it is housing the head of the pancreas inside it. The duodenum is the anterior relation of the right kidney. Then what you can see over here is that the pancreas, in fact, if you look over here, you can see another cut section of a reflection of peritoneum. This is known as transverse mesocolon, which is nothing but the reflection of a double layer of peritoneum from the posterior body wall and then attaches onto the transverse colon, which is hanging over here. The transverse mesocolon obviously has been removed from here, but you can imagine that the right end of the transverse colon, somewhere over here, which is known as the right colic flexure, that's going to be the anterior relation of the right kidney. The transverse mesocolon or the transverse colon extends all the way to the left side, and its left end is the left colic flexure, which is then going to be the anterior relation of the left kidney. The left kidney, in addition to the transverse to the left colic flexure, is also related anteriorly to the stomach, which is lying in the left hypochondrium of our abdominal cavity. It is also related anteriorly to the spleen, which is close to the fundus of the stomach. So the stomach, the spleen, and the left colic flexure are going to be the anterior relation of the left kidney. In addition, we can see the pancreas, the body of the pancreas extending to the left as the tail, and the tail being the anterior relation of the left kidney over here. Posteriorly, what we can see is that the diaphragm is kind of extending behind both the kidneys. So the diaphragm is the posterior relation of the kidneys as well. Behind the diaphragm, if you look from the posterior side, we can see that the kidneys are related to the ribs over here, to the 11th and the 12th ribs, which are the posterior relation of the superior poles of the kidneys. Since both the diaphragm and the ribs are extending behind the kidneys, so the peritoneal extension between the diaphragm and the ribs, which is the costodiaphragmatic recess, that is going to be extending behind the kidneys as well. So from front to back, behind the kidneys, we've got the diaphragm, the costodiaphragmatic recess, and then we've got the ribs serving as the posterior relations of the kidneys. Now let's try to identify the different coverings or wrappings of the kidney, and these could be better understood by looking at a horizontal slice which has been taken through the abdominal region where the kidneys are present. You can see that this is the horizontal slice, and the lateral body wall is shown over here. This is the posterior body wall over here. This is the anterior aspect of the slice, and you can see the abdominal pelvic cavity is going to be in the front over here. The cut section of the kidneys is shown over here with the hilum on the medial side, through which the renal vein, artery, and the renal pelvis are exiting or entering into the kidney. So now if you look over here, so the kidney is surrounded by a connective tissue capsule, a fibrous capsule over here. Outside the capsule, the kidney is further surrounded by a layer of fat shown in yellow over here. This is the perinephric fat. The perinephric or the perirenal fat is going to be enclosing the suprarenal gland as well. So it is a common covering for both the kidneys and the suprarenal gland. On the contrary, the fibrous capsule was specific to the kidneys only. So outside the perinephric fat, then we've got another layer of fascia, which is known as the renal fascia. Renal fascia once again encloses obviously both the kidneys and the suprarenal gland and anchors the kidneys to the posterior body wall. And then outside the renal fascia, we've got another layer of fat shown once again in yellow over here. That is the paranephric fat. So if we start from inside and make our way outside, we've got four different coverings of the kidneys. We've got the fibrous capsule of the kidney, unique to the kidney, and does not enclose the suprarenal gland. The remaining three coverings are the perinephric fat, followed by the renal fascia, and then the paranephric fat. These three coverings are then going to enclose both the kidneys and the suprarenal gland. Now here you're looking at the right kidney from the front. If you look along the medial margin of the kidney over here, you'll see a slit-like opening on the medial margin. This vertical slit-like opening is known as the renal hilum. Renal hilum is the vertical slit-like space through which different structures enter or exit the kidney, such as the renal vessels shown over here, or the lymphatics and nerves, and the renal pelvis, which is the dilated beginning of the ureter. The hilum then continues, this slit-like space, which is the hilum, that continues internally to create a space within the kidney, which is known as the renal sinus. Now, the renal sinus is going to be inside the kidney, so we can't really see it over here, but it's going to be inside the substance of the kidney. So in other words, the hilum, which is a vertical slit-like opening over here, that is the gateway for entry into that space known as the renal sinus within the kidney. Now remember that we talked about a covering of the kidney which was known as the perinephric fat, which was lying outside the renal capsule and was enclosing both the kidney and the suprarenal gland. That same perinephric fat all around the kidney, that actually passes through that vertical slit, the hilum, and enters into the renal sinus, the space within the kidney. And therefore, as a result, that perinephric fat is surrounding all these structures which enter or leave the kidney, enter or leave the renal hilum, such as the renal vessels and the renal pelvis. And in a way, it provides some kind of a fixture, some kind of a support to these structures as well. Now, the structures which can be seen passing through the renal hilum, either entering or exiting the kidney, they're always present in a sequence from front to the back. So, from the front to the back, we've got the renal vein, followed by the renal artery behind it, and then the renal pelvis is going to be the posterior most relationship, the posterior most structure within these three structures in the hilum. And if you know the orientation of these structures, that helps you orientate the kidney as well, comparing identifying the front and the back surfaces of the kidneys. Now here you are looking at a cut section which is taken through the right kidney. You can probably appreciate that the kidney tissue can be divided into an outer lighter rim or a lighter region which is known as the renal cortex, and an inner relatively darker region which is known as the renal medulla. The inner darker region, the medulla, is actually characterized by the presence of these pyramid-like structures. These are known as the renal pyramids, and the renal pyramids are separated from each other through renal columns, which are basically extensions of the renal cortex coming down over here into the medullary region, separating the renal pyramids from each other. The renal pyramids, as you can see, are triangular pyramid-shaped masses, the base being adjacent to the renal cortex and the apex on the directed on towards the inner side. The apical parts of the renal pyramids are known as the renal papilla. So you can see a renal papilla here, another one here, another one here, another one here, and so on. Now, if you're aware about the structure of the nephron, you can probably imagine the convoluted tubules of the nephron lying over here in the superficial cortex. Whereas the Henle's loop and the collecting tubules are going to be coming down into the renal medulla. Loads of collecting tubules are going to be aggregated over here in the renal medulla, and these collecting tubules are going to open up into the renal papilla, and through the renal papilla they're going to open up into the minor calyx, and as a result the urine which is formed inside the nephrons ultimately through the collecting tubules is going to be draining through the renal papilla into the minor calyx. Several minor calyces, for instance here and here, and similarly several minor calyces here, here, and here, they all join together to form a major calyx. The major calyces, two or three major calyces, they combine together to form this dilated region over here, which is known as the renal pelvis. So in fact, we're in a way talking about the anatomy of the flow of the urine, starting from the collecting tubules of the nephrons being poured into the minor calyx, and from there into the major calyx, and then eventually into the renal pelvis. The renal pelvis then exits the renal sinus, which is this space over here. See, it's filled in by the perinephric fat. The slit-like opening, the renal hilum, is the gateway for these structures to exit the renal sinus. So the renal pelvis can be seen exiting through the renal sinus, through the hilum of the kidney, and then continuing down as this narrow structure, which is known as the ureter. The ureter is then going to take the urine down into the bladder. Right, so now let's talk a little bit about the blood supply of the kidneys. Starting with this illustration over here, you're actually looking at the posterior body wall, or the structures related to the posterior body wall. You can see the big vessels over here, the abdominal aorta on the left side on the posterior body wall, and the inferior vena cava on the right side of the aorta. At the second lumbar vertebrae, the right and the left renal arteries can be seen arising from the aorta. Since the abdominal aorta is on the right side of the inferior vena cava, therefore the right renal artery has to take a longer route by passing posterior to the inferior vena cava before it manages to reach the kidney. Each artery then runs transversely, and at the hilum of the kidney it divides into several branches which then enter into the kidney. At the hilum, the renal veins can be seen lying anterior to the renal arteries. Both the renal veins, they drain into the inferior vena cava. The left renal vein is longer as it has to pass in front of the abdominal aorta and behind the superior mesenteric artery, which is this ventral branch of the aorta. So it actually passes in between the superior mesenteric artery and the abdominal aorta before it is able to reach the IVC, the inferior vena cava. An aneurysm of the superior mesenteric artery can potentially compress upon the left renal vein that could lead to an impairment of the flow of the blood, and that is also that could also present with the varicocele as well, because what you can see over here, this is actually the left testicular or the left ovarian vein, the gonadal vein draining into the left renal vein. And if the renal vein gets compressed, then the backflow of the blood over here can lead to an enlargement of the plexus of veins around the testes, the pampiniform plexus of veins, which is around the testes, that gets dilated, resulting in a condition which is known as the varicocele. The lymphatic drainage of the kidneys is through the lateral lumbar aortic lymph nodes, which are present around the renal arteries. Now let's talk a little bit about the ureter, which is carrying the urine from the renal pelvis, from the kidney all the way down into the bladder. So let's just start with this illustration over here, and let's just orientate the structures over here. So what you can see is the posterior body wall, the kidneys resting on the posterior body wall, and we can see we're looking at the posterior body wall from the front. You can see the two large vessels in the center over here, the aorta being on the left side, splitting up into two common iliac arteries, and then the inferior cava, vena cava on the right side, again being formed over here by the union of the two common iliac veins. We can see the different muscles in the posterior body wall as well. For instance, this muscle over here, that's the psoas major muscle, shown over here as well. This bony rim over here is the iliac crest, and above it we can see some other posterior body walls muscles such as the quadratus lumborum, and this region over here is the iliac fossa. Within the iliac fossa, we can see the iliacus muscle. So we can see the posterior body wall muscles over here very nicely. This region over here is the bony margin, which is known as the inlet of the pelvis. It's also known as the pelvic brim. You can see the promontory or the prominence of the sacrum over here, and the sacral bone is going to continue down into the pelvic cavity. This region is the pelvic cavity. We can see the different viscera residing in the pelvic cavity, the bladder, which is kind of collapsed, and you can see the fundus or the roof of the bladder over here. Behind that, we can see the uterus and the cervix probably have been cut over here, and so we can see the lower end of the cervix maybe continuing down as the vagina. The rectum has been cut over here as well, and you can see the lumen of the rectum. So the three different viscera or the components of those viscera are shown in the pelvic cavity here. Right, so now after orientating this picture, we can actually now, we're in a position to talk a little bit about the course of the ureter, right? So what you can see here is the renal hilum, the vertical slit-like opening on the medial margin of the kidney on the left and on the right side. You can see that this dilated structure which is coming off from it, that is the renal pelvis. The renal pelvis then continues down as the ureter. You can see that the ureter continues down. It descends on the ventral surface of this posterior body wall muscle, which is the psoas major muscle. And ureter, along with the kidneys, remember, it is a retroperitoneal structure. So all these structures are going to be covered over by the peritoneum. These are extraperitoneal structures. Now, as the ureter descends on the psoas major, we can see that trajectory of the ureter over here nicely on the radiograph. You can see the minor calyces combining to form major calyx, and the major calyces combine to form this renal pelvis, and then pelvis continuing constricting over here, continuing down as the ureter. You can see the ureter to be related anteriorly to the transverse processes of these lumbar vertebrae. So that's an important relation to know. And if you follow the ureter down over here, you can see this bony margin, that is the pelvic brim, which we already talked about in the illustration. And the ureter is going to be crossing over the pelvic brim, and the point where it crosses over the pelvic brim is the same place where the common iliac arteries or the veins can be seen bifurcating into the external and iliac vascular structures. And this is an important relation to know because the ureter is actually can potentially get compressed against the posterior bony pelvic brim, and therefore, as a result, this is an important site of compaction of the ureteric stone because of the compression against the bone. Now, at then, if you follow the ureter, you can see that it turns anteromedially at the level of the ischial spine, and then it enters tangentially, obliquely into the upper lateral corner of the bladder, one on either side. So the ureter is then going to enter into the bladder and pour the urine into the bladder. At the pelvic floor, in case of males, the ductus deferens or the vas deferens, that's a structure which is going to cross the ureter superiorly. And in case of females, the uterine artery is going to cross over the ureter. That this is an important relation to know because the ureter, because sometimes as part of a procedure which is known as hysterectomy, where the uterus has to be taken out, the surgeon can accidentally tie off the ureter along with clamping the uterine artery, and that can lead to different post-op complications such as hydronephrosis. Now, each ureter, if we follow the course of the ureter, we can see that each ureter is constricted at three different positions along its course. At the junction of the renal pelvis and the ureter, so this dilated renal pelvis, it constricts over here to form the beginning of the ureter. That's the first point of constriction. Then where the ureter crosses over the common iliac vessels at the pelvic brim, so at this point over here. And then the third point of constriction is where the ureter enters tangentially obliquely into the urinary bladder. These 3 points of constrictions are important to know because these are the potential site of compaction of the urinary stone. The ureters, they receive, as far as the blood supply is concerned, the ureters receive their blood supply from branches from the renal arteries, from the common iliac vessels over here, and from the internal iliac arteries. The lymphatic drainage that follows the pattern of the blood supply, and eventually the lymph drains into the lateral para-aortic lymph nodes and into the iliac lymph nodes. Now, the innervation of the ureter is important to know. Pain from the ureter, such as the ureteric colic caused by the distension of the muscular wall due to, let's say, because of the presence of a kidney stone, is carried to the spinal cord segments T11 to L2. So from the 11th thoracic spinal cord segment to the second lumbar segment. This is important to know because the ureteric pain is often then referred to the corresponding dermatomes for these same spinal segments T11 to L2. And these corresponding dermatomes, they cover over the posterolateral abdominal wall, below the ribs, so from the back in the lumbar region and continuing down into the pubic region all the way down into the scrotum in the males and the labium majus in the females. So the pain of the ureteric colic kind of spreads down from the loin in a semicircular fashion down all the way to the groin region. And this knowledge of the referred pain and the spinal cord segment innervation of the ureter basically helps us to identify the site of the pathology potentially inside the ureter based on the neurological examination of the dermatomes. Now let's talk a little bit about the urinary bladder. So as a first step, let's orientate this illustration over here. What we are looking here is basically a mid-sagittal section which has been taken through the pelvic region. You can see the anterior body wall over here. The anterior abdominal muscles can be seen over here. This is the pubic symphysis, a cut section which has been taken through it. And at the back over here, you can see the cut section taken through the sacrum. So this is our pelvic cavity, and you can see the pelvic viscera inside the pelvic cavity. We're looking at a male hemisection, a male prosection, an illustration of a male prosection. So we can see two visceras over here, the bladder in the front and the rectum at the back. The rectum continues down then as the anal canal. The bladder continues down as the urethra, which can be seen over here. Right, so the adult urinary bladder that can be seen lying within the pelvis over here, when it is empty, it is totally an intrapelvic organ, but it can, when it becomes distended with bladder, it can even extend into the abdominal cavity. The empty bladder, as you can see here, is kind of a pyramid shaped structure. It has an apex to it, which is directed to the front, and then it has a base, which is at the back, directed posteriorly and inferiorly, and then a roof, which is also known as the fundus of the bladder, and two infralateral surfaces, which we can't really appreciate that nicely because we're looking at a hemisection. Infralateral surfaces are more clearly visible when you look at the bladder from the front or from the inferior side. Apex, as we mentioned, is going to be projecting towards the pubic symphysis. The base, which is directed posterior-inferiorly, is kind of triangular in shape, and in fact, the triangular region within the base is where different structures such as the ureters and the urethra come in or come out. That is known as the trigone. We'll have a look at it probably in the subsequent slide. The two ureters can be seen entering into the base of the bladder in its upper lateral corners, one on the right, one on the left. You can actually see the opening of one of the ureters at the top over here. This is the triangular region in the base, which I mentioned, that is known as the trigone. We'll have a look at it in a bit more detail later, much more clearly in another illustration. The bladder then continues down as the urethra. You can see the beginning of the urethra over here from the lower corner of the base. The neck is the most inferior part of the bladder, and this region over here is the neck of the bladder, which is going to be surrounding the urethra or forming the origin of the urethra. The neck is anchored to the pubic bone by fibromuscular bands. The wall of the bladder, if you look over here, you can see that it is muscular. It contains a smooth muscle inside it, which is known as the detrusor muscle. And that muscle, when it contracts, that creates mucosal ridges inside the bladder, which are known as the rugae. And the internal, the smooth muscle which surrounds the urethra here at the neck region, that contributes to the formation of the internal urethral sphincter, and this is actually the beginning of the urethra over here, which is known as the pre-prostatic urethra, and the urethra then continues down into the prostate. An important function of the internal urethral sphincter is also to prevent the retrograde ejaculation of the ejaculatory fluid of the sperms into the bladder during ejaculation. Now here we're looking at the front of the bladder. In fact, the front of the bladder has been removed and we are looking at the inside of the bladder cavity over here. You can probably appreciate once again over here the thick layer of the muscle which is lining the bladder. This is known as the detrusor muscle. This is the wall of the bladder, and inside the bladder you can see that the mucosal lining is characterized by these longitudinal prominent folds. These are known as the rugae. These prominent mucosal folds are created because of the contraction of the detrusor muscle. However, what you can appreciate is that at the base over here, which is the posterior part of the bladder, you can see that in the base the mucosa is not folded. This area is rather smooth. This smooth triangular region in the base of the bladder is known as the trigone, which we already referred to in the previous slide when we were looking at the hemisection. But the trigone is much more clearly visible if you look at it from the inside. You can see that it is triangular. Its upper and lateral openings over its upper lateral corners over here, they are characterized by the opening of the ureters. You can see the ureter opening on the right over here, the left ureter opening over here, while the lower corner of the trigone, that is actually marking the beginning of the urethra. The smooth muscle inside the wall of the bladder contributes to the formation of the internal urethral sphincter over here. And we can see the urethra beginning down over here and continuing down into the prostate, for instance, in case of males. Now let's talk a little bit about some of the important relations of the base of the bladder. Remember, the base is the posterior part of the bladder, and it is directed posteriorly and inferiorly. So what you can see over here is a hemisection which has been taken through a male pelvic region. You can see the bladder in the front over here, the rectum at the back. This is the same hemisection which has been taken through a female pelvic region. So we can see the bladder and the urethra in the front. We can see the vagina and the cervix and the uterus in the middle. And then we can see the anal canal going up as the rectum. Right, so in case of a male, if we start from over here, you can see the base of the bladder can be seen at the back over here. That's the base of the bladder. This is the roof or the fundus of the bladder. The base of the bladder is related posteriorly to this structure over here, which is known as the seminal vesicles. And there's another structure which serves as a posterior relation of the base, which is the ductus deferens, or to be specific, the ampulla of the ductus deferens. Right, so where are these structures coming from? Well, if you go down over here, we can see that we can see the testes inside the scrotal sac, and right behind the testes, we can see a structure which is clasping the testes from the back and kind of extending on the superior pole of it. This is known as the epididymis. The epididymis temporarily stores the sperms in it once the sperms are received from the testes. The epididymis then extends inside the spermatic cord as the ductus deferens, also known as the vas deferens, which then passes through the inguinal canal and then eventually enters into the pelvic cavity. Once inside the pelvic cavity, the ductus deferens or the vas deferens is going to go in front of the ureter, and that's an important relation to know. It then crosses the ureter and goes to the back of the bladder. That's where it becomes dilated to form what is known as the ampulla of the ductus deferens, or the ampulla of the vas deferens. That ampulla then combines with this structure here, the seminal vesicles, which also contributes to the formation of the ejaculatory fluid. And the two structures, when they combine together, they form what is known as the ejaculatory duct. And you can see the bladder, the neck of the bladder resting on top of the prostate. The ejaculatory duct then goes into the prostate and drains the ejaculatory fluid into the prostatic part of the urethra. So the seminal vesicles and ampulla of the ductus deferens are posterior relation of the base of the bladder. The ejaculatory duct in itself is going to go into the prostate and then combines with the prostatic part of the urethra. In case of females, the base of the bladder, which can be seen over here, you can see that the base of the bladder is related posteriorly to the vagina. So vagina is the posterior relation of the urethra as well as the base of the bladder. The cervix and the uterus are higher up. In fact, in a non-gravid uterus, the uterus would be actually lying on top of the roof of the bladder, or in other words, on the fundus of the bladder. So the uterus is not the posterior relation of the bladder, it is in fact the superior relation of the bladder. Now let's talk a little bit about some of the peritoneal reflections onto the different pelvic visceras. We know that the bladder is an intrapelvic organ, so it's an intrapelvic organ, but it is an extra peritoneal structure, which means it's outside the peritoneal cavity. The superior surface of the bladder is, however, covered over by the peritoneum. We can see this is a male prosection over here, or an illustration of a male prosection with the bladder and the rectum inside the pelvic region. This is the female prosection with the bladder and the uterus and the rectum inside the pelvic region. The peritoneum can be seen, for instance, over here, it can be seen extending from the body wall onto the roof of the bladder, and then from here it then jumps over to the rectum. In case of females, we can see the extra organ over here, the uterus residing in between the bladder and the rectum. And so the peritoneum extends from the body wall onto the roof of the bladder, and from the bladder it jumps onto the fundus of the uterus, a little bit on the body, and then the fundus of the uterus. This pouch, which is created over here because of the reflection of peritoneum from the bladder to the uterus, is known as the vesico-uterine pouch. It is a little bit shallower as compared to this second pouch over here, which is created by the reflection of peritoneum from the uterus onto the rectum, which is known as the recto-uterine pouch, also known as the recto-uterine pouch of Douglas. From here, the peritoneum then extends onto the posterior body wall and then continues as the parietal peritoneum. In case of males, we have only two viscera over here, the bladder in the front and the rectum at the back. So we've got only one pouch because of the reflection of peritoneum from the bladder onto the rectum, which is known as the rectovesical pouch, which is the same as the rectouterine pouch in case, or the or the rectouterine pouch of Douglas in case of the females. Now, these pouches, the rectouterine pouch of Douglas and the vesicouterine pouches, these pouches, these peritoneal recesses and these pouches, and these are clinically important as they determine the spread of infection and fluid inside the peritoneal cavity. These pouches are in contact with the paracolic gutters, and the paracolic gutters, they provide a pathway for the flow of the fluid with gravity down, while the recesses and the pouches, these are the potential sites for accumulation of a fluid inside them in case of different diseases, such as the pus accumulation could actually happen over here, and any exudative fluid in case of peritonitis could actually accumulate over here. In case of trauma, the blood could actually accumulate over here, and these pouches, when seen filled, in case, let's say, of a CAT scan, they signify some kind of an intra-abdominal pathology. Now, since the bladder is an extraperitoneal structure, the superior surface of the bladder is covered over by the peritoneum. You can see that over here as well. Normally, the bladder is an intrapelvic structure, which we can see over here. That's the normal positioning of the bladder. It lies inside the pelvic cavity. Now, as the bladder fills up, it extends out of the pelvis, and it lifts off the parietal peritoneum away from the anterior body wall. It kind of peels the parietal peritoneum from the body wall and lifts it up as it goes into the abdominal cavity. This is important to understand as it permits the suprapubic catheterization of the bladder, which can be seen happening over here. The suprapubic catheterization is done through the anterior abdominal wall and is performed when it is not possible to catheterize the bladder through the urethra. For instance, when the prostate is pretty enlarged, that could be one example. The procedure involves inserting a catheter through the anterior abdominal wall above the level of the pubic symphysis. Now, the catheter can be passed into the bladder without any damage to other structures because the bladder is already distended and it has lifted the parietal peritoneum up. So there are no chances of the catheter passing through the peritoneum into the peritoneal cavity. We don't do that procedure normally because in an undistended bladder, if we do a suprapubic catheterization, that's going to pass through the peritoneum into the peritoneal cavity, creating peritonitis. The blood supply for the bladder comes from the superior and inferior vesicular arteries, which are ultimately branches of the internal iliac artery. We can see those vessels over here in this illustration, where we can see the abdominal aorta splitting up into two common iliacs. The common iliac, for instance, here can be seen splitting into external iliac and internal iliac. Internal iliac then gives off several branches. This is the internal iliac on the other side over here, and you can see the superior and inferior vesicular branches coming off from the internal iliac supplying the bladder. The superior vesicular artery supplies the upper part of the bladder, including the fundus of the bladder. The inferior vesicular artery then supplies the lower part, including the seminal vesicles and the ampulla of the ductus deferens, which were as we discussed, these were the posterior relations of the base of the bladder. In case of females, we have the uterine artery and the vaginal arteries, which supply the lower region over here and sometimes tend to replace the inferior vesicular arteries. The venous drainage is through the veins running along with the arteries, which drain eventually into the internal iliac veins. The lymphatics and the innervation of the bladder, they usually follow the arteries. The lymphatic drainage is into the iliac lymph nodes. The nerve supply, the autonomic innervation to the bladder, comes via the inferior hypogastric plexus. Now, from the bladder, the urine then enters into the urethra. The male urethra is approximately 20 centimeters long. It has two bends to it and is divided into four different parts. The first part is the pre-prostatic urethra. The pre-prostatic urethra is really short in length. It extends from the bladder all the way to the prostate gland. You can see the neck of the bladder resting on top of the prostate, so you can imagine the pre-prostatic urethra, which is the first part that's going to be really short in length. Here, the urethra is surrounded by internal urethral sphincter, kind of shown in color-coded in orange or brown over here. The internal urethral sphincter is formed by the smooth muscle inside the wall of the bladder. It is involuntary, and the sphincter prevents the sperms to enter into the bladder during ejaculation. So, in other words, it prevents the retrograde ejaculation of the ejaculatory fluid. As the urethra passes through the prostate gland, this part would be known as the prostatic part of the urethra, and that is the second part of the urethra. There is a longitudinal midline fold inside the urethral mucosa over here. That longitudinal mucosal fold is known as the urethral crest, and that urethral crest possesses a circular elevation in the middle, which is known as the seminal colliculus. This elevation is used by the surgeons to identify the position of the prostate gland during surgical resection of the prostate. We cannot, however, appreciate those structures over here. The urethral crest and seminal colliculus are not clearly seen over here because we're looking at a hemisection, and therefore we're looking at the prostatic urethra from the side. These structures would be better visible when we look at the prostatic urethra from the back over here. Now the urethra, then as the urethra passes through the after the urethra has passed through the prostate gland, the urethra then enters into this pouch-like region over here, which is known as the deep perineal pouch. The deep perineal pouch is covered at the top over here by a structure called the pelvic diaphragm, which is the main muscular floor inside the pelvic cavity. Once it passes through here, it enters into the deep perineal pouch. Inside the deep perineal pouch, this part of the urethra is known as the membranous part of the urethra. This is the third part of the urethra in case of males. And here we can see that the urethra, the membranous urethra, is surrounded by another muscle, which is a voluntary muscle. This is known as the external urethral sphincter. Now, the floor of the deep perineal pouch is formed by a membrane called the perineal membrane. And we said the part of the urethra inside the deep perineal pouch is the third part of the urethra, which is known as the membranous urethra. This membranous urethra then pierces the perineal membrane and enters into this region, which is known as the superficial perineal pouch. So, the superficial perineal pouch in the perineum is just underneath the deep perineal pouch. The superficial perineal pouch is characterized by the presence of the erectile tissue and the muscles attached to them. One of the erectile tissue, which you can see over here, is known as the corpus spongiosum. This is the beginning of the corpus spongiosum, and it is dilated, forming a structure which is known as the bulb of the penis. So you can see the membranous urethra then continuing down into the bulb of the penis and then running inside the corpus spongiosum. This part is known as this part of the urethra. This is the fourth part of the urethra, and in fact is the longest part in case of males. And this is known as the spongy or the penile part of the urethra. Immediately on entering the pouch over here, the urethra, as it enters into the bulb of the penis, you can see that it is making a sharp bend over here, and here the urethra is vulnerable to injury during catheterization due to the abrupt change of direction. The urethra then continues in the corpus spongiosum to the external urethral orifice, which is a vertical slit inside the glans penis. The glans penis is actually part of the corpus spongiosum. It in fact is the distal dilated ending of the corpus spongiosum, and the urethra is always going to be running inside the corpus spongiosum. When the penis is flaccid, there is a bend over here where the urethra passes from the root of the penis into the body or the shaft of the penis. And then what you can see over here are some glands. These are known as the bulbourethral glands, which contribute to the lubrication inside the urethra. And you can see the bulbourethral glands themselves are lying inside the deep perineal pouch, but their ducts are draining into the penile or the spongy part of the urethra down over here. Unlike the males, the female urethra is short, approximately 4 centimeter long. It leaves the bladder and passes through the pelvic floor to enter into this region, the deep perineal pouch. So this would be the membranous part of the urethra in case of females. Here inside the deep perineal pouch, the membranous urethra is surrounded by the external urethral sphincter. The urethra then pierces the perineal membrane to enter into the superficial pouch. This part of the urethra is really short in case of females. It opens into a region known as the vestibule between the two labia minora. The lower part of the urethra is attached to the anterior wall of the vagina, and it is lying anterior to the vaginal orifice inside the vestibule.